the incarceration. Thank you. This is the Incarceration Prevention and Reduction Task Force's Behavioral Health Committee, and we're meeting here remotely on April 28th, 2023. And if you can scroll down just a little bit, Jill. There you go. Thank you. Before we begin, we'd like to acknowledge that we're gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us here together today. And please join us in uncovering such truths at any and all public events. So I'll go ahead and call this meeting to order. We have our guest today from Lummi Nation. I'd like to begin with an introduction from them. And then I'd also like to, just to take a look here at our list. I'd like to actually, when our guests from Lummi Nation are finished, I'd like to go through and have each of our members just identify themselves and who they're with so that our guests can have some context here. And I'm going to go ahead and invite our guests from Lummi Nation to introduce themselves.
Hi, good morning. This is Dina from Lummi Counseling Services, and I am Rosalie's successor, interim director.
Hello, everyone. I'm Jesse Davis. I'm the medical director of the Lummi Healing Spirit OTP. Happy to be here. Thank you for the invitation.
My name is Vanka Patterson. I'm a health policy analyst, employee of the Lummi Nation. Good morning.
Good morning.
Hi, Switchill. Good morning. Maureen Kinley, council member for the Lummi Nation. Dan, I want to thank you for having us today. Appreciate being here.
Thank you.
And Renee Ramirez, program sponsor of the Healing Spirit Clinic Opiate Treatment Program.
Welcome. Is that everyone?
Sorry, I missed the intros. Mike Hilly, Emergency Medical Services Manager for the county.
Folks, just go ahead and chime in. I'll call on you. Just make it quicker. Brian.
I'm Brian Estes. I'm co-president of the National Alliance on Mental Illness, NAMI, the Whatcom County chapter.
Brian.
Good morning. I'm Brian Thane. I'm executive director of the Bellingham and Whatcom County Housing Authorities.
Mike Parker.
Good morning, everybody. Mike Parker, day job is an opportunity counsel. I do housing and healthcare integration. I'm honored to be your co-chair and really honored to have our guest today. Welcome.
Perry.
Good morning, folks. Perry Mowry. I work with the Response Systems Division within the Health Department. I'm oriented towards supporting behavioral health services, do some contract administration, that sort of thing. Looking forward to hearing more about the programs and so forth in Lummi. Thanks.
Donnell.
Good morning. I'm Donnell Tanksley, the Chief of Police with the City of Blaine. Thank you.
Mike Smith.
Hi, I'm Mike Smith, clinical supervisor at Lake Whatcom Center, Heart Crisis Team.
Heather.
Good morning. My name is Heather Flaherty. I am on this task force as a citizen representative, and I'm also really grateful. I serve as the executive director of the Chuckanut Health Foundation as well.
Doug.
Good morning, Doug Chadwick, Undersheriff with the Whatcom County Sheriff's Office.
Mike, you already introduced.
Hey, Dan.
Yeah.
I was just wondering if everybody at Lummi is familiar with the Incarceration Prevention and Reduction Task Force.
Our guest from Lummi, do you want us to give you a brief overview of the task force?
Sure, that would be great.
Okay. So and folks, correct me if I stumble here, if I make any missteps in my presentation. I'll be brief. The Incarceration Prevention and Reduction Task Force was formed, I think it was in 2015 after the first vote for the jail failed. So the task force was formed to look at alternatives to incarceration. Obviously, incarceration prevention and reduction, it's in the name, to reduce unneeded jail stays, basically. And so some of the accomplishments of the task force are the Crisis Stabilization Center, which is known as the Ann Deacon Center for Hope. That's out on Division Street. That's a 32-bed facility, 16 beds for mental health illness treatment, and 16 beds for substance use disorder. Coming out of the task force are also a few programs that some of them originated here in this room, so to speak. The GRACE program, ground level response and coordinated engagement, which works with about 100 people to avoid unnecessary 911 calls, helps reduce the call load on that system, helps folks get the care that they need. And then the LEAD program came out of the prosecutor's office, but many of the ideas came from the task force. But Eric Ritchie, the prosecutor, was a leader in putting that together. That's law enforcement assisted diversion. And that program currently works with about 110 people to avoid contact with the criminal justice system, and helps folks get basic needs as well. And then another program that did originate fully in this room was the alternate response team, and that is Bellingham's response to behavioral health, certain types of behavioral health calls. Instead of sending a police response or a fire department response, the response is a nurse and a designated crisis responder that goes to non-dangerous behavioral health calls. I guess I'll just put it that way. And so those are some of the things that we've worked on and contributed to over the years. Does anyone else want to add any other any basic things about the task force or about this particular behavioral health committee?
Yeah, and I would just offer one additional piece. I thought your coverage, by the way, was great for a really fast summary. You know, the committee is aware that that not everybody experiences a criminal legal system equitably. And so the IPRTF brought up, and then the county council adopted the GARE Alliance on Racial Equity. So we attempt to do everything that we do using a racial equity lens. And we're aware that the criminal legal system definitely just does not impact us all the same. And so we're increasing our work in that area as well.
Thanks, Mike. Brian, did you have something to say? Brian Estes? You're on mute.
Yes, real quick. Sorry, I was muted. And someone needs to help me with this because I may not remember all the committees, but the overall task force has various subcommittees or committees. We're the Behavioral Health Committee. There's a Law and Justice Committee. There's another committee that deals with data, I believe. And I'm sure I'm missing one or two other ones. Just so you understand kind of the scope and how it's organized. And then also, just as a caveat, the Prevention and Reduction Task Force only deals with issues that pertain to people 18 or older.
Yeah, good point. Thanks, Brian, and thanks, Mike, for chiming in and providing some more clarity. I want to talk about why folks from Lummi Nation are here today. I was in a meet and greet probably about a month ago, maybe a little bit more, and met Maureen, LIBC council member, and we had a great conversation about the similar challenges that we were facing regarding fentanyl and treatment options and things like that. And I had a follow-up meeting with a group of folks from Lummi Nation, from the treatment center, and two LIBC members. And I just was, and Rosalie, just really blown away, who's an elder, was blown away by the stories that I heard. And I just felt there's a commonality in the things that we're facing when it comes to this crisis with fentanyl use in Bellingham and also at Lummi Nation. And so I wanted to invite folks from Lummi Nation to come out or to come to this call today to share their experiences, what's going on in their community, how we can help each other. And I wanted to then offer the things that we're doing as well. So that's kind of the rationale for today, if that makes sense. And I'll go ahead and turn it over. I don't know who's going to lead the discussion from our guest today, but I'll go ahead and turn it over at this point, and maybe a presentation, then we could take some questions at the end.
Dan, thank you again. Maureen Kinley, Tribal Council. I'm going to kind of open up and introduce the team here. And then I'm going to have to jump to, we have a council meeting scheduled this morning, so I'm going to have to excuse myself after I do the introductions. I want to talk about a little bit about what we're doing here at Lummi regarding the fentanyl crisis. On February 1st of 2022, the LIBC declared a fentanyl crisis. And then on March 15th, the LIBC through resolution established the Lummi Nation Drug Task Force. So I think we're kind of thinking along the same lines, that, something needs to be done, and it's going to take all hands on deck to get this done. So some of the core focus areas that we're looking at here at Lummi through our task force is strengthening housing and wraparound services, workforce development, assess treatment needs and resources, build up prevention, strengthen enforcement, gather and analyze data, and assess policies and codes that's internal, local, state, and federal, whatever affects us here at Lummi. So I kind of wanted to open up with that. And then, we had some good discussions, Dan, and I'm glad that you were able to come out and visit us, and then also allow us to share some of our information with you and some of the things that we're doing and some of our stories with the group here. So thank you again for allowing us to be here. And with that, I am going to turn it over to Dina and Renee for their presentation. So thank you all, and I am going to excuse myself so that I can get into our council meeting.
Thank you, Councilmember.
Thank you, Maureen. We're going to turn it over to Renee, who would like to do a presentation, if that is okay with you.
Absolutely.
Okay, and we will go from there. Thank you.
Okay. Thanks.
And I don't see a share button on here. And I apologize for my dogs in advance.
No
No
worries.
COVID and working from home.
Yep, I hear you.
Hi, Jill Nixon here. I'm gonna go ahead and promote you to panelists, and then you should be able to share. There you go.
There we go. We can see that. We're not getting any audio if there's audio associated with this.
Oh shoot, sorry.
Okay, there you go.
Yeah, I just wanted to say, so we thought we'd use this community presentation, and so we're not going to delve into these topics of the medical side in regards to addiction, as a lot of you know about it, but I think it's important to realize all the things that the community needs to be aware of, so they have an understanding of just all the physical and psychological dangers and just what leads to addiction, because a lot of some of these topics like historical trauma can have its own week, but I think the results or the effects of it, it cascades into physical, emotional, mental, and spiritual and cultural damage. So each one of those really is a topic unto itself, but we want to talk about how we've through the history here at Lummi, we've created the programs we have. So this one's an important one. How do you build or rebuild the lost life? So from Lummi's perspective, there's multiple ways to reach home, and there's no one way to recover. And we shouldn't judge a person by his path. Obviously, some paths are more difficult than others. If you think about people that go into jail, there's a lot of stories of how jail transformed their lives. We'd prefer that they would out of their own free will do want to get better, but we know how strong the addiction can be. So just recognize that they're alive at this moment in time and they're moving forward. And so we want to encourage that. And so harm reduction is important, and being tribal sovereign cultural application is really important. And so love and care is what drives Lummi Nation's sub-programs. But of course, we coordinate care with other departments, so it's not just us as a treatment center. And so I really like this slide where it says, find your tribe, love them hard. So a lot of us don't choose our families. Sometimes we have great family members, other times not so well. And so we'll have to create our own family. And then these are important quotes I thought that talk about recovery. We're all just walking each other home. Do not give up. The beginning is always the hardest. Pain is real, but so is hope. And there's always something to be thankful for. I think in addiction, there's always the attitude of gratitude as a slogan. And so these are even though this focused on harm reduction, it encompasses all of the treatment services. So a big one with us, of course, is medication-assisted treatment. So we have monobuprenorphine for pregnant women, Suboxone or buprenorphine naloxone for everyone else. We also have the naltrexone tablets and the monthly injection, and then buprenorphine monthly injection. And then we're in the process of getting methadone just because of the effects that fentanyl has had on the community. And then in regards to the models of care, we're from the Lummi Counseling Services. The opiate treatment program is part of that. And so we're the opiate treatment program, which is daily dosing and observed DUAs and counseling. And we also have a cultural room, and that's really important for that spiritual and identity aspect of a person's journey into recovery. And then something that's not here in this as a part of the model of care, but really important for our opiate treatment program, is feeding clients. So some of these clients, like deep in their addiction, they have nowhere to eat. And so we provide breakfast, lunch, and dinner and snacks for them. And so some of them will tend to spend the whole day, and in our evenings, when we're open in the evenings, they'll spend their evenings with us too. We also have an office-based opiate treatment program that's part of the tribal health clinic. So people that don't need such a high level of care like us, they will go to the clinic at times to seek treatment there. We recently also created a certified community behavioral health clinics attestation, and so that's for the ones that need even a higher level of care than us, more supportive living. You can think about it as a crisis respite center, so a place where they'll come in to see us, but they don't have anywhere to sleep or be a safe place to be. We can put them in this modular, it's a 7-bed facility that'll be staffed with nurses and CNAs and security. So it's modeled like a secure detox center, but it's an outpatient detox. And then we also have the sequential intercept model that we're in the process of working through with a grant. And we're trying to embed a substance use professional counselor with a peer support counselor to do ride-alongs with Lummi Nation Police Department, so that we can do a diversion, like jail diversion from there, in hopes of them getting treatment. And then we have prevention. So not just focusing on treatment, but also on avoiding our youth coming into treatments. We have a couple of different ways. There's a state grant that helps us provide cultural based practices. So during the summer, there's canoe clubs, and so the kids will exercise. I think it's 5 days a week. Dina can correct me, 5 days a week, and then they'll travel one day, and then the canoe clubs are there like one Saturday afternoon and then Sunday morning, I believe. So that's during the summer. But then we also support kids that are doing extracurricular sports, so like basketball, football, golf, or other drug-free events. Through our grants, we're able to support them in their work. You don't think about it as work, but that keeps them busy and keeps them out of trouble. So that's really important. And then there's, in regards to harm reductions, we have overdose prevention and safer drug use education. So there's a harm reduction program at the clinic, but some of this overlaps with them. Like we have Clexato now, which is a higher dose Narcan. And then we have counseling services, primary cares at the clinic, engagement services. There's contingency management that's been found to be useful, or evidence-based practices for methamphetamines. And then also transitional housing, that's also an engagement type service. And then recovery support services, which also falls into housing. Transitional housing is also a recovery support services, so that falls into both. And then we have peer support counselors and recovery coaches. So people that have lived experience are able to walk with them, like you saw in the earlier quote. So they need that extra support. Sometimes when you're deep in your addiction and you see somebody come out of it, that has a real powerful effect. And so that's really important to have those services. The expansion of services, that was the certified community behavioral health clinic. So thinking about the whole person. So even though we're addiction medicine, we really think about the, not just the physical, but the psychological, the mental health, and the cultural piece of a person's care. With the CCBHCs, one of the things that caught my eye is one of the phrases they use is having services from cradle to the grave. And so when we look at Lummi's overall services, they really do provide all these services in regards to pediatrics and prevention, just following the person throughout their lifetime. We have funeral services, and that's another department. And so again, it's just looking at the whole person. So that holistic cultural healing treatment approach, which we call wraparound services. And this is just something that I used in regards to how things change, and we can't be afraid to change with the times to treat people. So originally in 2013, we started out as Suboxone only. And then once fentanyl was seen in the community, there was a referendum for methadone. And so we had to make that change. And then these are just comments on people, which I think a lot of us, that's what encourages us with the work we do. This one I really like. I have been clean for more than a year now. I'm an honest person and responsible mother, someone my children can look up to. I am in a strong, healthy, and happy relationship with the love of my life as we both get treatment from the Suboxone program. I was homeless when I began the program. Now I have my kids back, my own house, a car, my very first driver's license. I have a bank account and actually save money in it. I owe all this to the Suboxone program. And so there's all these really great stories that we hear. And of course, these comments, we're only sharing the positive ones. There's also negative ones on how we can do things better. And so those are patient surveys that we have our clients fill out every year. And so I think that's also another important part of getting information from those you're treating and how you can improve. So originally we were just treatment, and with time, the other expansion of services, the rescue meds, the community education, the outreach didn't used to exist. The expansion of services didn't used to exist. So so you saw the positive ones. There's also things of how we can do things better. So I didn't share those, but I think it's important to know that there's always room for improvement. And we may think we might be doing things that are helping, and sometimes they are, most of the time they are, I think, because we use evidence-based practices and cultural-based practices, but sometimes there's the few that you don't want to fall through the cracks, and so you have to focus on those. This last year we really focused on the homeless. We were able to house 60 individuals, and out of those 60, we were able to get 12 or 14 into treatment, and they're still continuing with treatment. And so unfortunately there's other ones that weren't ready, but we're happy that we made that effort to help them, and we're able to catch those 12. And so those are the little things that you always have to look at, how you're doing things and improve or change. yeah, so you got thrown a lot of information. And like I said, some of those, like the CCBHC, that's like, we're going to a conference in a few weeks, and that's like a whole week on the CCBHC. Same on recovery, peer support, and then rescue meds. And so we're just here to share what we've learned. And if you have any questions, I guess we're happy to answer them.
Committee, any questions? I'm here for another about 10 minutes or so. And Mike, and then I'm going to hand it over to you.
Well, you're right, Renee, that was a dazzling amount of information and really impressive. And one of the things I was thinking as I watched is some of the things you're doing are really cutting edge. And in some communities, they're not really embracing harm reduction as a strategy. Could you maybe comment on what it was like in your process to just add such great services in your community? Did you have to do coalition building? Did you feel like there were families or elements of Lummi Nation that were not as excited about, you know, kind of your philosophy of harm reduction and voluntary services?
Yeah, I've been here for 10 years, and I think Dean and Rosalie are on the call too. So correct me if I'm wrong with something, Rosalie. But so when I started 10 years ago, the OTP program, I remember there were people not happy with it because they were talking about how, oh, you're just substituting one drug with another. And so now, so the education back then was putting it in a place where, again, love and compassion, people can have compassion for somebody. So we would talk about, you know, when somebody's diabetic, you don't judge them for them taking a pill or injecting insulin. So you think about a diabetic, what they tell you is, okay, you know, your blood sugar's high, you can change your way of life, change your diet, exercise 5 days a week, you know, cut out all these things from your life, or I can give you a pill. And so, you know, they make the decision that, and I don't know that they 100% make the decision, but they take into account their circumstances and say, well, I'll take a pill or an injection. And so that one is to educate them on that, you know, maybe you do have a choice and you choose the medication. There's the other piece of, like, you think about a young kid that grows up in a big city where there's a lot of pollution. So that environment affects them. The air they breathe in affects them. And with time, it damages their lung. And guess what? They develop asthma or some kind of pulmonary disease. And are you going to judge them for taking their inhaler? You know, you're not going to judge them for taking their inhaler. And so why would we judge somebody that we know more than likely had a really tough childhood? You know, they suffered. We know that addiction, that's where the other slides in addiction and those things, that's where that education comes in, and understanding what it means, where, you know, you grow up in this painful environment, and it's easy to see why they would start using substances. And we know that's not the case with everybody, but that's a case with a lot, how the environment affects. There's been research at NWIC too, the Northwest Indian College, in regards to racism really affects kids. And then sometimes I'll share my story in regards to growing up in a violent city. So I grew up in Compton for part of my childhood. And I didn't learn this till I was an adult, but if you grow up in a violent environment where you fear for your life, words don't hurt you as much. And so when I came up here, there was racism, and it's like, well, that doesn't really hurt like a bullet to the chest, right? So like it's strange how you rationalize these things, but if your environment is somewhat stable, like free from physical harm, those words really have a high, like they have a lot of power. And so you see like suicide rates too. And so all that kind of comes together, and you just have to talk about it and educate the community. But those are the biggest things of, like, you know, a child with asthma, you'll never deny them their inhaler, neither an elderly person with diabetes, and maybe not even such an elderly person, but just someone that develops a disease with time. You don't judge them for taking medicine. So that's the part with the Narcan or the opiate treatment program, so medication assisted treatment, but then also that played into the Narcan or the rescue med, because once you explain the different stages of the disease, some, like we mentioned, the Obon, the office space where they get a prescription. That works great if you're like somewhat stable, but if you're on the lower level or a higher level of care, then you need that daily dosing. And then even if you're sicker than that, where you need involuntarily to be involuntarily committed, you know, there's all these spectrums. And so once you explain just the addiction process, the different phases of addiction, it's easier to have compassion and understanding, as opposed to just making it emotional. Even though you do, I mean, we are tugging at heartstrings when we talk about the kids, right? Not judging them.
Yeah, it sounds like you did a lot of community education and really kind of spread your learnings and that wisdom to overcome any resistance. Yeah, thank you.
Oh, and I give Rosalie and Dina, like they were here before me, so that's stuff that I learned from them. Yeah.
I'm going to call on Heather Flaherty, then Mike Parker. I'm going to turn it over to you at this point. Okay. And guests from
Gotcha.
Lummi, thank you so much for attending. I do have to run, but thank you. And I hope this conversation continues. Have a good rest of your day, folks.
Thank you.
Thank you, Dan. Renee, that was an incredible presentation, and I'm just absolutely blown away. I have 3 questions. One is, I'm curious how things are going and how are the outcomes, and do you feel like, you know, since you declared the emergency in February, have you seen any improvement in the, you know, in decreasing deaths and tragedies? And my second question is, how is Lummi Nation addressing any violent or property crime associated with addiction and drug use? And so if there's an individual who we want to have compassion and treat, and that maybe they're also committing a different kind of crime that we need some accountability for. I'm just curious about the approach and how you handle that. And then my third thing is that I have heard that the Healthcare Authority and Lummi Nation are hosting an opioid summit in sometime this spring, summer, maybe May 22. I have a wonderful colleague who just dropped off some coffee. I'm very lucky. And I wanted to let you know that the Chuckanet Health Foundation and Whatcom County Health Department and a couple of other partners are working to also host an opioid summit in June in partnership with the University of Washington. And I would love to have just better understanding and connection to not duplicate the event and support what Lummi Nation is doing. So those are my 3. I wanted to get them out and then I'll go on mute. So let me know what you think.
Yeah, I should have grabbed the slide from our harm reduction program. So they have like a direct line with EMS services in Whatcom County, and they've been keeping track of overdose deaths. And I can't give you numbers, but from what it looks like when they compare throughout the years. And so Lummi's been really pushing to have Narcan and now Clexato out in the community, like for over 10 years. I want to say maybe like 15 or 20. And so during the pandemic, all the deaths were a lot higher than they used to be. And so again, thinking about the social isolation, all that, the mental effects of it, it's easy to understand why that happened. But Lummi was pretty stable in regards to deaths. It didn't see that huge jump. And so that had a positive effect on overdose deaths, we feel like. And then in regards to, sorry, the second question,
How are you approaching the harm reduction, compassion, treatment with addiction if there are also violent crimes associated with that behavior around that individual?
Yeah, so that one I'm gonna refer to Dina because she brought up an interesting point in regards to us losing a lot of Lummi tribal members.
Care and compassion with.
Okay. Hi, everybody. This is Dina. I'm sitting here with Dr. Jesse, Josie, and Vanda. And just the connection with what you're asking, Heather. I did get to sit down with, I can't believe the gentleman that just left the meeting. And we talked about The fentanyl, when we called the fentanyl declaration in Lummi, of course, we're front line. A lot of people show up at our doorstep. We did not shut down throughout the pandemic. The doors stayed open thanks to Renee's team and our a few others that just diligently worked through everything. And so when the fentanyl came to our community, the way we identified it was the person was testing negative in all their UAs, and everything looked good, but they looked awful. And it took one of our nurses, our Jenny, who is an ARNP, yeah, PAN, and so she identified like something's wrong here. These people aren't looking healthy. It's got to be something. And so when we heard about fentanyl, they got the fentanyl strips and they start testing for fentanyl, and everybody just start testing positive left and right. So it was just already flooded in our community by the time it got to our attention. And what has come into the community just, you know, came in a big wave like it always does, whether it was with the oxy or all the waves before that, methamphetamine, just the way it works. But right now, I don't feel like the fentanyl is getting any better. We're doing everything in our power. That's why we're sitting here with you guys. And we're trying to partner up, and we're really trying to listen to what everybody is saying throughout Washington State, all the way from law enforcement to the drug task force to the political side, asking, you know, that it's going to take a whole lot of help to get this problem under control out here in not just our community, but everybody's community in the United States, is what we're seeing. And that was something that we talked about. And I know when it came to our attention that we had a bunch of homeless people in Bellingham, that was really shocking to Lummi. Our people usually don't wander off the reservation. Not that many. I believe there was 50 to 60 Lummi members behind Winco. So when we sat down with Jay Martin, who's our chief of police, and we sat down with our team, we kind of came to conclusion after going out there ourselves. I, Dr. Jesse, and Renee, our chief of police, went back there to talk to all our loved ones and asked them what it would take to bring them home. And a lot of them were ashamed. A lot of them didn't want their loved ones to see them the shape that they were in, because they were totally just, you know, homeless. With the habilitation was awful. And so the other reason was because out in Lummi, we still have a code where we can charge them if they do have, you know, we do find fentanyl on them. We take that charge seriously. And I think with the law that's in Bellingham, the Blake law, it gives them a little bit more leniency to go out and do what they're doing without getting the help that they need. So I've kind of seen that I just really don't know how to word that, but it really isn't helping our loved ones, because for some people that are out there using an addiction, they need that bottom. They need that bottom of jail, you know, prison, whether it's CPS, whatever it is. But if you don't have that bottom and you're just getting cut loose every time you're out there breaking the law or using, you know, in public, the bottom becomes death. And so we're seeing a lot of overdoses. And so that was something that, to me, that really stuck out to me when we went out there and talked to our loved ones. So I'm hoping that something changes in that aspect, and to give our people a chance, you know, because when you're out there lost in addiction, it's true, you're blind and deaf. You don't hear anything, and you don't see anything you're doing until you have that awakening. And that awakening usually happens in jail, or it happens, you know, whether you're in treatment or whether you wake up in a prison cell and you wake up and you can't believe that, wow, I did all this. This is the damage that I've caused. That, look at all the people that I've hurt. I mean, you don't see all that until you wake up somewhere in a facility such as jail. I think, and that's what I shared with the group last week, and just on a personal level. And then I and my mate are in recovery, so we know how that feels to to do that damage and not know the damage you've done until you've had that awakening.
Yeah, and I just wanted to add, Dina, we have a contract with Chehalis Jail.
Yeah.
Is that, yeah, so the way people were treated, the Blake law wasn't applied like it was in Bellingham. And so again, those paths, one of those paths is accountability. And so, for example, again, with the OBOT model and the OTP model, there's a lot more care and well, not care and support. There's like the observed UAs. The OBOTs don't have to do observed UAs, which is fine if you don't need that high level of care. But if you do, then you just kind of play games with the PCP, whereas with us, that accountability is important. And so again, the jail being accountable to the community is important, because if not, unfortunately, if you need that care and you're not getting it, you're just going to run amok and do damage, as we've been seeing.
Yeah, so we did talk with, oh, go ahead, Renee, sorry.
Oh yeah, because currently I didn't show this actually. I forgot, so I apologize. I can reshare the screen if you want. But we're working on a secure, involuntary secure withdrawal management services facility. And so again, we have to change all the codes to be able to take them against their will, put them in the medical bed, and take care of them, because they're just not being safe. So just another path, a lot nicer than jail. But again, they don't want to be there, but they're gonna be put in there. And then in regards to the oh, sorry, Dina, you had another comment too.
Yeah, so we were just talking about the jail topic. The reason that came up, like I said, we talked with Claudia Murphy, who was out there and behind there at the homeless encampments. They were so out of control, the ones behind Walmart all the way to Winco, just everywhere here in Bellingham, and just affecting not only Bellingham, but all the way down to Seattle. And, what we can do to clean up, our community was really tough to go out there and witness. And that was something, when you're not able to arrest somebody, and I know all of us are from Bellingham, and we do a lot of shopping in Bellingham, and just not feeling safe to go in your own grocery stores, or seeing people that actually stealing right in front of you. I and the director from behavioral health were actually at Fred Meyer's, and we were just witnessing people walking out with just cartfuls of stolen goods, like right in front of, the whole tarnation, and they couldn't do anything about it. They just had to let them go. And so those are the behaviors that we're talking about, that we have never seen so out of control in any drug epidemic throughout that we've seen here in Lummi. Fentanyl is the worst one by far, and now we're getting tranq dope coming our way. And so it is, for us, we don't feel like it's getting better, but we're trying everything in our power and our ability to make sure that we can help the individual when they're ready. And so this is why our stabilization center is so important, because sometimes we don't have a detox bed right away. They're getting full. And I'm not sure if Bellingham did pass a law to where they are arresting people in Bellingham now, but we are seeing a lot more people coming home. And it's been crises after crises throughout the week in our program, dealing with individuals that do not want to detox off of fentanyl, because it's so hard to detox off of. And they said it's 10 times worse than the oxy and heroin, and they're scared to detox from fentanyl. And so that's something that really sticks out to me too. And in the long run is what we're dealing with. I don't know if Dr. Jesse, if you have anything to add with the clients you see.
Yeah,
Patients?
kind of just to echo what Dina's mentioning. It is incredibly difficult to safely detox and successfully detox off fentanyl, as opposed to other opiates, heroin. For example, if somebody was using short-acting opiates like an oxycodone or heroin, they could wait 8 to 12 hours, and we could give them supportive medications, and they could do fine. And we could start them on, through a traditional induction with Suboxone, and they do quite well. Unfortunately, with kind of the pharmacokinetics and dynamics of fentanyl, it's a very short acting high in the moment, but it's almost like building a reservoir in their fat tissues over time. So if we have people, smoking 20 upwards of 100 pills a day, they're going to have a very high reservoir, and they're going to start to feel withdrawal at that 8 to 12 hour mark, and they're going to start, and they might take a Suboxone film and actually throw themselves into worse withdrawal just because of the nature of the interaction between fentanyl and Suboxone. So that's what we're up against. And we're having to have patients wait 24 upwards of 36 hours before they can start the medication as a traditional induction. And that's a long window and a lot of time for that motivation to go away. And if they're feeling the worst flu symptoms of their life, all we can do is give them supportive medications for that sort of thing. And, with those learned behaviors, they know one way to get well in that moment, and that's to use fentanyl again. So that's what we're up against. And, Dina mentioned things like trank dope, and drug dealers are being very innovative, and, we have to do the same. And that's, why we're, thinking outside the box and doing these temporary facilities, and with a long-term goal of, both a secure and voluntary secure withdrawal management facility. So we're doing what we can, and I really commend the tribe and this program for really doing everything they can, from giving somebody a meal to going across the state to take them to treatment or bring them back home to get care. So they're really doing all they can here, and I'm really happy to be a part of this program. So
Thank you, Jesse. Okay. And so we just want to thank you guys for listening and taking time to care of what's going on here in Lummi Nation. And we as a whole community, countywide, it's affecting everybody, not just one individual, but the whole county. And we do understand the seriousness of what is going on in our community and how it has affected businesses, families, the person that's suffering in the disease, the children that are, that are dying, the overdose that, that happened with the 5-year-old just recently in Bellingham. I've personally, haven't been in contact with somebody that was affected in that situation. And that's really heartbreaking because it affected not just those, but a lot of people and the schools as well. So we do bring a lot of awareness to Ferndale High School, Lummi Nation School. We work with, we have tribal members that work at the Ferndale High School as well as Vista, the middle schools, and we connect and we make sure we bring that awareness when needed, and especially, when the pills look like candy today. They're so easily, you just breathe it in, you can get a contact high, and you don't know what to do and why you're feeling so fuzzy or weird. And that's something that we need to bring awareness to our children and our youth that we're worried about, because we've always been big on our youth as well, let alone addiction. So it's affected the whole realm of our community as well as many others. So
Just to have them.
Thank you.
And we really appreciate the discussion, and I don't know if you all still have time to stay. Renee, I was really intrigued about the slide that you missed, and I think Heather might have a follow-up. I don't know, Heather, you still had your hand up. So if you all still have some additional time, I know the committee would love to continue to stay in dialogue. How does that sound for you?
Yeah, I'm home alone. I don't know the other team.
Great.
Dina or Vanda, I think Vanda was there because Heather had asked a question about the summit. And honestly, I can't keep track of them. We just do what we're told, so we show up. But Vanda, can you speak to the one happening? Because there's two, and I'm not sure which one's happening when. The fentanyl summits.
Yeah, so there's a couple coming up. So there is the state fentanyl opioid summit hosted by Lummi Nation. It's invitation only, and it really is bringing together the leaderships of the state of Washington up to the governor's level and tribal leaders into a forum so that basically they can really evaluate and assess and come to some immediate thinking about what can they do immediately, what steps can be taken right away to help address the fentanyl crisis affecting the tribal communities, what needs to be done kind of on the midterm, kind of take a little bit longer, and then the longer term goals. And it's really looking at having all the high level secretaries from the state of Washington, to be participants, active participants in on panels and work groups and work sessions and so on. But as regards attendance at that, the best thing that I could do is Jill has my email, so I can put folks in touch with Councilman Nick Lewis, who would be able to give more information about that and the specifics about some of the activities and participation. So if that helps with that, and that's coming up on, let me see, 1 second. So that's May 22nd, 23rd at the Silver Reef Casino. But as I said, it is invitation, and it is important to go through Mr. Lewis to check on participation in that, and we can assist you. So Jill, just feel free to send folks my email and I can help make those connections. And then you've got the National Tribal Fentanyl Opioid Summit. It's actually the first, my understanding is, National Tribal Fentanyl Opioid Summit. It's actually being hosted by the Tulalip tribe at the Tulalip Casino. That is open to all. The registration is going to be going up soon. That's organized by the National Indian Health Board and the Tulalip Nation. That's August 22nd through the 24th. And again, it's a high-level conference summit, really getting into the heart of the matter to address the impacts of the fentanyl opioid crisis that is affecting all our communities. Yeah. So if you have any questions, I'm happy to answer them. So other than that, that's the date.
Thank you for that. Heather, did you have a follow-up?
Yeah, I'll be quick. Thank you for that information. That's incredibly helpful. And I personally want to do anything I can to support. And I think as a community, we all want to support and work together to address this crisis. The University of Washington is hosting an opioid summit as well in June, June 27th and 28th, I believe. And Whatcom is going to be, it's a hybrid summit. Whatcom will be a site for them. And that's the partnership with the health department and the Chuckanet Health Foundation. And that one will be open to anyone in the community and focused on harm reduction and grief and how we support people. So I'd love to share that information all around. And Lummi, of course, we'd love to work with you on making sure that's complementary to anything that you all do at your summits. And in response to some of what you shared, I do want to just let you know that Bellingham did pass an ordinance that allows law enforcement to arrest people for possession of open drug use. And there's others on this call that could share all the details of that. And that may be a positive thing for Lummi, like you were saying, people maybe are coming home now because there's consequences in Bellingham again. But what's really compelling to me is your work with looking at involuntary commitment for treatment. And I'd love to learn from you on that journey, because that is something that we've been talking about too, is that something to kind of reconcile that harm reduction and compassion with, is jail the right place, and not wanting to criminalize addiction, but needing that accountability mechanism. So excited to learn from you and your journey on that.
I see Mike and Brian, but Renee, really quick, I see your hand up.
Yeah, I just wanted to mention a comment that one time we had a big council and part of the community was there, I believe, in regards to that, because we were, I was raised with the USA way of thinking of like, you're an individual first. But we're all really kind of family and connected, whether we want to be or not. And so one of the things that general manager at the time said, they said, they're being involuntarily committed to the jail. If you think about it, they're going against their will to the jail. And so it's not any different. So that was how like it felt like a slap to the face, really, because I'm like, well, I never thought about it that way, because it's from my point of view, it's like, well, that's a slippery slope to go through. How are you going to do that? But it's about protecting the community, protecting the families, right? Nobody wants to, if you have an option between burying your loved one or taking them against their will to a medical facility, hands down, the medical facility is the way to go. And so I just want to share that.
Thank you for that, Renee. Mike?
Yeah, thank you so much. And Renee, I deeply appreciate your presentation from the clinic and what all the work you're doing down there. And I want to let the group know that, our office has been trying to help the clinic out in a small way on this. And a couple of things that we do is every time EMS goes on a call in that area, in your area, we get an alert that an overdose is going down or Narcan has been delivered. And we immediately get a hold of the clinic over there, let them know what's going on so they can go out and get an engagement at that point in time. That started about 4 years ago with Dr. Ishikawa and Megan Bailu. They've now moved on. However, we have some recent conversation with Haley Olson and Dr. Morgan, who I've not yet met, on about how to improve that system, make it even better for you, because you have a bit of a model here that we want to emulate in EMS, which is our next project is to migrate into see if we can do some MAT in the field at the point of engagement with maybe our alternate response teams and people that once we wake them up, have a conversation. Is this the day you would like help? If so, we can use arrive with some Suboxone, go up to the stabilization facility, and then figure out how to best help. And so you guys have created a small model for that we want to emulate and grow larger. And we're having some framework building conversations on that. And so I just really enjoy the relationship. Anything we can help improve that for you guys, we really want to do that because in your community, everybody and where people are, and you want to take care of them. So I think it's important. The second thing that we're doing is, in fact, we were going to present at the council meeting today, but that didn't make the agenda. However, we won a SAMHSA grant, Substance Abuse Mental Health Services Administration from the feds, to put on 2 EMT courses that are primarily oriented toward the tribal communities and the rural areas. So we are having an EMT course up in the tribal administration office this summer. And interestingly, and I'm so tickled about this because this was word of mouth, and we already have 40 people signed up. Most of them are from either the Lummi or Nooksack community. And the idea was a couple-fold. One is a workforce development idea, but the other part is to see if we can get people in your community that might want to do this work. And on the back of this EMT module or this EMT class, 2 modules. One is specific for SUD understanding. It'll be a high-level overview, and then the second module that goes with is understanding mental health issues and sometimes how they, are one and the same. And so out of that class, we hope that the EMT students would graduate and maybe provide some of that type of service through your clinic or through your organizations as you guys grow these programs as well. So I'm really excited to work with the community on this. And with the EMT course especially, I'm hoping it'll be something that the Lummi Nation, would be able to help build inside for your community to respond to these things. So just want to let the teams know that we're trying to develop that, and anything EMS can do with this response, please let us know.
All right, Brian, does you have your hand up?
Yeah, thank you, everyone from Lummi for presenting today. And you did talk about an emphasis going out to the schools and talking about drug use and other issues. And I just wanted to let the whole group know here that NAMI Whatcom, in conjunction with Whatcom Community College, Whatcom Family Community Foundation, and Mad Hope, on May 3rd at Whatcom Community College, we're having a condensed screening of the Ken Burns film Hiding in Plain Sight about youth mental health. We're going to have a number of organizations there. We're going to have a panel discussion with professionals and young folks with lived experience in mental health. It's May 3rd at Whatcom Community College, 6 to 8:30 in the Heiner Theater. It's free and open to everyone. I will send the flyer for this to Jill, and maybe she can send it out to the whole group. But we would welcome any and all from Lummi Nation to attend this event. Thank you.
All right. I don't see any further questions, and I want to thank our Lummi guests for staying with us an entire hour. So thank you for your time, your wisdom, and open hearts and sharing, and the idea of collaboration and moving forward on something that's impacting all of our community members so intensely. It just, it's probably the first hope I felt in a little while. So thank you for bringing some of that hope and your innovation and your spirit, and for sharing it with us today.
Yeah, thank you. Did you want me to show you the SWIMS model?
If you have
Real
additional
quick?
time, Renee, we would absolutely love it. We do have room on our agenda. I just wanted to be really gentle on your time because you've been so giving. So I would love to see that. Yes.
Okay, it'll be quick.
Okay, thank you.
Yeah, this is an entrance, and this is something I think I heard Josie. Josie actually had a vision on this and drew it up. She's our architect. And so some things we talk about in regards to culture, you see these light, like natural light is, I kind of skimmed through the cultural slides, but just connection to the earth is really important. So nature, there's a sweat lodge for the secure facility, but then also for the community. It's something that's been asked for a long time. This is an outer entrance for privacy for the involuntarily commitments. And then there's a healing room, which was modeled out of a smokehouse, where people can do a song and dance. And then the little courtyard. There's the 2 sweat lodges. And so that's kind of, you see the healing room, dining, and then patient. And so the longhouse is how Lummi people used to live in the past. And so it's a 16-bed facility on one of the wings, and then you see the normal kind of setup in regards to the other things. Yeah, so that's, I just wanted to share that since you were interested.
And Renee, just a follow up, you mentioned involuntary. Is it 100% involuntary? Is it a mixed population at this particular
No,
facility?
it would be mixed, but our understanding is we have to create it as an involuntary facility due to regulations, but it'll be both.
Okay.
And then Lummi's substance use departments are the only departments that see non-tribal members. So if there's non-tribal members living in the community of someone in the household, like if we're treating somebody in the household and they have someone significant other or somebody else living with them, then we're able to treat their family or their associate, I guess. So again, thinking of what COVID taught us, that we're all affected. So we're seeing the same thing with fentanyl.
Thank you for that, Renee. Committee members, anything else for our esteemed guests before we let them go and get back to their days? Perry.
I hesitated just because I really wanted this information and so forth, but I thought I might share something with you, Renee, and your colleagues. Goodness, this had to be 10 years ago. I was at a Region 3 retreat, and Lummi Nation was doing a presentation on Suboxone and on that approach. And I should have prefaced this a little bit and giving some context. I'm an old CDP from way back, further back than I'm willing to admit. And I don't know that I was diametrically opposed, but I certainly held the opinion that, it's like, oh, this Suboxone and methadone, we're just getting people addicted to another substance and, et cetera. But I'd come around, I tried to understand it. I just was not, I was not in it, to win at that point in time. And I think it was Rosalie, I'm not absolutely certain, but there was a presentation that went on. I went to, of course, the presentation, I listened and, and so forth. And After the presentation, again, I know it was a woman, and I spoke with her. I think that it was Rosalie, and I said, help me to understand that, you know, this thing about, are we just changing seats on the Titanic? It's an old, you know, CDP kind of thing. The whole boat's sinking, and we're just, you know, supporting, you know, individuals getting addicted to a different substance. And her response to me was, we have to figure out a way to keep people alive. And then maybe we'll continue to grow and continue to have knowledge and be able to work with that person, which of course we can't do if they die. It wasn't that I was argumentative, I was truly seeking information, but it had a major impact on me and a real shift in my thinking, because she was willing to take the time to have the discussion. And I shared with her that I wasn't trying to be argumentative, I really wanted to learn. And really it was through that compassion and the time that she took that it, you know, had a really significant impact on my professional thinking and personal thinking. And I carried that, I won't go into the detail, obviously, but I carried that through a number of steps in my profession as a trainer, as an educator, as an administrator for multiple programs related to SUD. So I just wanted to share that. Wasn't sure that it was appropriate for this meeting, but I thought I'm going to, because I really appreciate your information and the sharing that you have and the efforts that you're making. So thank you.
Thank you for sharing that. That really means a lot to our staff and our team here, sharing the words of wisdom from our elder, Rosalie Scott, who has been in this field for, I believe, over 30 to 40 years. And that sounds just like her, what you just said. And we are really blessed and honored to work with her and our elder, Josie Jones, here at the table, that have been out here since my grandpa Ernie very first started his AA and would go out and help people that were just out in the street having a drink. And I mean, the history goes so far back, from CDP to SCDP to Suboxone to the, you know, medicated assisted treatment programs, and just the shift in everything that we've seen through time and the era that we're in today. So thank you.
Under Sheriff Chadwick. So Doug, I think you're still muted.
No, I'm not. Renee, earlier in your presentation, you talked about you're either in the process or you've instituted a program where you got behavioral health specialists riding with the Lummi Police Department. So I was just kind of curious. It's very similar to the co-responder program that we're rolling out now with the sheriff's office. So was wondering if that is in place and how that is working for you out there on the reservation.
No, it's not in place yet. We got a SAMHSA grant for that, and so we're still working on. We're hiring for the positions, and so actually, any advice you have for us or lessons learned would be beneficial. We actually heard of the program that Swinomish gave us the idea. They were trying to start that out, but I guess they were never. They lost the person in charge, and so they were never able to get it off the ground. But it seems like a good idea. It's part of the evidence-based practice for SIMS. Yeah.
Again, I think for us, it's the kind of the evolution of, especially being out in more rural parts of the county, trying to call a resource to come to them if they're co-responding with a law enforcement officer. You've got that safety perspective, but you're also delivering services where people are in a timely fashion. So we're looking forward to continuing to move forward with that program, but it's in its early stages.
Mike Smith.
Sorry to be a late comer, but I hope you still have time to address this. I really want to thank you and your team for coming in and sharing some of that knowledge with us and some of the things that you guys are doing. A couple of questions. Contingency management, you guys talked about that. Could you tell us a little more about that? And do you have a needle exchange currently on the reservation?
Yeah, contingency management. The counseling program has had trouble getting that going, but we work with another through Cascade Medical Advantage through their Spoken Hub network. in the past. And so they have that. So when people give Clean UAs, they'll get a gift card to Fred Meyer or somewhere where there's a necessity to fill for them, like a support type service. So that's been effective for meth use, according to SAMHSA. And then the needle exchange or harm reduction program at the clinic, the tribal health center, they have that. And there has been issues brought up with that, unfortunately. And so they've been trying to work out different ways to not end that program, because there's been some issues. I guess people just leave needles all over the place, and so they give them sharps containers in hopes that they'll put them in there, and there's sharps containers across the community in various areas. But lately I haven't heard. I think it has to do with people aren't injecting fentanyl anymore, so I think that's why there's been a decrease. I'm not 100% sure, but there still is a needle exchange program, to my knowledge. And then Dina has
Yeah.
a comment.
I was just gonna repeat what Renee said. The needle exchange has come, it's pretty low out here now, considering everybody's using fentanyl and smoking fentanyl, inhaling instead of injecting. And so that, I mean, there are still IV users, but it's not as many. Today, everybody prefers to smoke fentanyl and Lummi.
You know, Renee, I had a follow-up. You mentioned trank dope, and I'm guessing that's one of the names for xylazine, right? I know the nerdy name. Yeah, trank dope. So obviously the committee's aware of this. And one of the things that we're aware of is in communities where it's spread faster and earlier, like East Coast, one of the ways that they unfortunately were finding how prevalent this was in their coroner's office. If you don't test for it, you may not know that it's in your community. You may not know it's affecting some of your folks. You know, how is Lummi Nation being made aware of that coming through? Is it really just people's attestation? Are you all in any way testing for it? And what do you think about that methodology for trying to figure out how widespread a certain problem might be by kind of enhancing what you screen for, what you test for, if we do have an overdose?
Okay, we're going to let Dr. Jesse intervene and talk about that. We do have a poster about trank dope. I don't know if Renee has that handy, but Dr. Jesse has been the one that's been addressing that topic.
Yeah, so you know, we, through our Lummi communications and outreach and prevention, we go to the schools, but we also do Facebook messaging and put it actually in our community paper. And so, yeah, trank dope or xylazine's been very prominent, primarily on the East Coast, and it's made its way over there, over to us. And we've been told it's as close as Bellingham. We've decided that we're going to start testing for it. We ask our new patients and some of our patients that are, you know, working on their stability, if they've had any exposure to it or heard of it. And a lot of them, I mean, no one said that they've noticed it yet. But it is, you know, it goes back to that, you know, these drug dealers are being quite innovative and trying to, you know, to put their hooks into people even more. And we plan on testing for it here. And I know that Chief Martin, he's got a couple samples that he sent out for analysis that haven't resulted yet. So we're going to see if they've returned anything on their end. But it's scary, very scary, because Cloxato or naloxone doesn't work for the xylazine portion of whatever illicit drug people are using. It does, I mean, we still recommend using it because the patient or the person will present the same way. So we are still giving people the instructions to use a Narcan or Cloxato like they would on any overdose. And but we're emphasizing rescue breathing in those instances as well, if they're not responding, and CPR if necessary. So I wish we don't have a point of care test just yet. I've heard and read that hopefully that's coming one day soon. But it's really interesting to see different ecosystems as far as the drug supply goes. I'm from British Columbia, and I worked at a safe injection site for a year, about 6 years ago, and all we saw was powdered fentanyl. And it was a lot of injection drug use at that point. People would smoke it as well, but primarily it was IV, and we didn't have the blues at that time. And we couldn't get, no one could get heroin and just across the border in the Fraser Valley. So come down here and with my training and working in Seattle, fentanyl has only really been a prominent part of the drug supply for the last couple of years, which is really interesting to see the divides and the different ecosystems. So we're trying to stay on top of it, and we're kind of at the mercy of the technology as well at this point. So
thank you for sharing that. Any other comments or questions for our presenters? You guys are going to get the award for being patient and hanging out for a long time. And we have a lot of questions. I did have another one about your facility, your behavioral health clinic. You mentioned it's for crises. And Renee, I guess I'll direct this at you and then send me to somebody else if somebody else can answer the question. But the new facility that you built, was that a voluntary facility, and how long can individuals stay? And I may have just missed that with so many different programs. I apologize if I missed
Yeah, the expansion of services, the CCBHC,
Yep.
that one is really the policies, I think, follow kind of what Lummi does, which is we just take care of the person, and so however long they need to stay there, there's not a set time, for example. So it can, I think that's the flexibility of it not being SWIM's facility. It's basically an expansion of what we already do. So instead of having somebody withdraw for 4 hours on the medical bed, we take them to an actual bed and say, stay here for as long as you need to. And then, you have the nurses here and then see us in the morning type of thing.
And that is 100% voluntary, that expansion of
Yeah.
services in that particular part. Okay, and then what I'm following then is that what you all are seeking, or what you might like to add to that constellation of services, is an involuntary, but also
So
ability
this
to
is
detox.
basically, like a phased approach, basically, is how we saw it. This is, since we can't have the inpatient secure involuntary, we'll do outpatient voluntary in the meantime.
Thank you for that. Chief Tank, I see you popping back in. Did you have something that you wanted to ask or share?
Well, no, it's not a question, but I certainly want to thank the Lummi Nation for the presentation. I thought it was great. The information we gleaned, certainly I believe that we can emulate some of those things here in our communities as well. So thank you.
Great, thanks. Mike, I see you have a hand up.
Yeah, thanks, Mike. Renee, I talked about a little bit earlier, we're getting into diversion programs here in the county. About 35% of the overdoses that we wake up from EMS bolt, right? They go against medical advice. They want to go to the ED, especially if you've already had one ED experience, and we are pretty know what that's like over there. So with the new facility, and along with our stabilization facility here in town, back to the MAT program, we are working on diversion programs. And so in your community, I'd love to get involved with that planning, because we would rather divert to this facility for your community members as opposed to the ED, as long as they're medically stable. And that would get MAT quicker on board. We're working with Cascade as well for a delivery program out in the larger county. So as you build that, we'd be really interested in helping you out for diverting from the ED for these select patients in your community. And I would add to that too, we need to figure out a way how to help out if one of your community members is not actually on the reservation on that call. So if we go out on an EMS call and, I don't know, where over by the mall or something, or they're in the city, how could we identify that person that would be one of your community members, and we could take them to your facility for that help? So we'd really be interested in figuring it out with the Lummi Nation.
Yeah, I think if Jill could share your email or my email with you, and then maybe do a memorandum of agreement or something like that.
Yeah,
Yes, that would
absolutely.
be
We'd love
great.
to work on that.
I just want to chime in and let you know that we would love to invite you to our grand opening and our blessing ceremony for the expansion of our services that is going to be happening on April 27th from 11 to 2 p.m. For this Recovery and Stabilization Center. We just wanted to put that invite. If we can send it to Jill, that would be great. And if Jill wants to extend those out, that way we can connect with you, Mr. Hilly. Yes, and we're really interested in talking with you as well and making those connections.
On behalf of the committee, we want to thank you again. I know we've said it a couple of times. This has been a really enlightening session. It's great sharing and just a wealth of knowledge. And you can see a lot of interest in the connection. So hopefully this is the first of some other, and we can find ways to mutually support each other as we try to help our community wrestle with all of this. So thank you again for all of your time. And subcommittee members, we have a little bit more on agenda, but we will try to be as quick as possible. And Jill, thank you for yet again being the go-between and helping us all stay connected. So I appreciate you, Jill, and everything you do to help us get going.
Thank you. It was nice meeting everyone.
Thank you again so much, all of you. Okay, well, my head's still swimming a bit, but all right, so we have just the other piece that was on our agenda today. If committee members remember, we did spend some time looking at our priorities. And this was squarely in one of our priorities. So I want to thank Dan Hamill and others for getting this set up. So I'm going to go ahead and share my screen briefly and show essentially what Jill has done. She's captured our conversation. So I'm going to go ahead and bring that up for you all. What I want to do is invite, first of all, tell me if you all can see it. I got a nod. Okay, good. All right, so this comes, these are elements, by the way. So Jill is working on yet again are going to be an update on the work of the committee for this year. But priorities for 2023, we developed quite a few, and that's not uncommon for this group. I think we see a lot of different needs. And what I hope today was just kind of invoke a little discussion, conversation. Does anything rise to the top for folks? So I'm sharing, I'm just going to scroll down. You can see the end. And you can see that xylazine fentanyl use in the community was clearly in there, right? Diversion from narcotic overdose in the field. So really today hit probably 3 to 4 of these priority types. But as your co-chairs look to create agendas that further our goals, we want to make sure that we're really hitting what you all think is really important and what rises to the top for the all. So I'll stop there. I think y'all can see this, and please do, and just jump off mute. Heather, please.
I would love to see data and help push that conversation. I don't, and also I hope all of you have seen the survey results from the stakeholder advisory process. Have you all seen those? The recent ones, and some of the comments are, I hope you read the comments, and I hope you've all seen that survey of what's feasible in the next few years, building a new jail, building a new behavioral health center, et cetera, et cetera. One thing that we've been talking about in real, like true, we need this, is we need data. And we've been talking about it since 2015. And I would love an update on, okay, did the prosecutor's office get their new system installed? And what kind of data is possible to get there? What's happening with our jail data system? What can we understand even with the systems we currently have? And what can our committee do to help if it's funding, right? If it's like just too expensive or too complicated, or how can we help? Because I still am just stuck on how do we know what we need to build, whether it's an intervention or a program or a facility, unless we understand who is in the jail and why and what their co-occurring issues are. And we don't really know that. And if somebody knows it, they're not sharing it in a really understandable way. So it's not just getting the data and the systems for that. And I understand all of the reasons around, systems don't talk to each other, but how can we help? What are the other options? And then making it meaningful for the community to understand the progress and the outcomes and what are our tax dollars achieving and what are our recidivism rates. And I'm really stuck on that it's been 8 years and we still don't really have a good picture or grasp of the data. At least I don't. So.
I took some on my own notes, not just relying on Jill, because I always rely on Jill. Very quickly, Jill, I did want to see what Heather's comment about the poll results and the stakeholder advisory group recommendations. Were those sent to the task force as a whole, Jill? Are those available to the task force as a whole already, or?
I believe they are, but I have a note to send you all the link after our meeting today, so I can forward that to you all right now.
Okay, great. And I see a couple people chiming, and I'm going to guess I got this right, and you will tell me if I got this wrong. I believe I've got Mike, Doug, and Brian. And if I got that wrong, my apologies. Mike, can you go?
I think Brian had his hands up first, but I'll go ahead and steal it. Sorry, Brian. I agree deeply with Heather's comment here. The data is out there, but it's just not centralized in a place to look at it. I think most of it's understandable, but it needs to be centralized. And we've talked about this for a couple of 3 years with the work that Jeremy Morden and now Amy Hockenberry's on over there under that sort of new health informatics. But I don't know that anybody's ever made the statement or said we need a community information exchange system. And what does that look like, in a framework or health information exchange? I think for our topic here is more of a community information exchange, and it would have a section on what are we doing about the opioid issue in our community, and then you could tie in all these things that you're talking about, Heather. So I just don't know, maybe it comes as a recommendation from us to reinforce that idea that we need to build a community information exchange. I don't know if it sits in this lane or not, but I really think that's kind of a high level solution for all of this is to centralize this. And I can give you one great example. We went and looked at San Diego, did a project that about 5 years ago we were trying to emulate, and it's called the San Diego 2-on-1 project or something like that actually had a great success and built a really good model for this. So, and this work began before the pandemic, by the way, so it just all got sort of stalled in that too, but maybe we could revitalize it from that perspective. I don't know.
All right, Under Sheriff Chadwick, and I'm sorry if I'm going brisk, but we do only have a few minutes, and I'm going to try and hit public comment and get us out of here on time. So Doug?
No, I was just going to say real quick, I understand Heather's frustration, and I know the index committee, and there's a lot of others. Unfortunately, there's a variety of different departments that hold information that's relevant to the conversation, but it's all siloed and it doesn't necessarily talk together. So I know there's discussions about hiring a data analyst to try and pull together those disparate systems and get that information into some kind of cohesive report. Maybe some kind of community dashboard that I know Spokane has something that you can search in other places. So I understand the frustration. Unfortunately, when it comes to, Brian had asked some questions about, how long does it take people before they're provided medications? That's not a data report. That's just anecdotally, 24 to 36 hours, which I think you heard from the folks out at Lummi that's pretty normal. But pulling an actual report of that is a little more challenging. So it has to be hand checked at this point. So.
Thanks. And Brian?
Real quick, maybe this committee should sponsor a hackathon on that issue. My other two questions. So did we have a meeting that maybe I missed on the strategy and metrics for evaluating the outcomes of LEAD and GRACE? Because it says that in progress report.
No, we did not, to my knowledge. Jill, can you correct my memory if I'm wrong? I don't believe we
Oh,
have hit
those-
that yet.
Yeah, those bullet points were pulled from past agendas. So Brian, I'll have to go back and look at past agendas and see where that item came from.
Okay, could you send that? Because that's a topic that's really important to me, and I don't, maybe we could revisit it a little bit. And finally, real quick, I attended a discussion last night about the new jail put on by Indivisible Bellingham, and Barry Buchanan was there, and he talked about that survey, I think that Heather was referencing. And one of the findings related to that was that people just don't trust the government, and their distrust with how money has been spent, the jail tax, how that's been spent. And this is probably going to have some kind of an impact, on a ballot measure if it is placed on the November ballot for new jail. It just seems to me, though, that there's a lot of information the general public doesn't understand about what's really been accomplished with that funding and the work of the overall prevention and reduction task force. And I just think maybe we ought to have that as an action item going forward. And I encourage people to look at that survey, and maybe Heather, you have a comment on that real quick.
I hope you check the incarceration task force website from time to time, because that is where I understand, Jill, people who write in with public comments, they get posted there. It might be on the stakeholder advisory site, but both of them. And I will say that Steve Harris wrote a memo about the 2004 jail sales tax. And that might be worth really understanding, even at the task force level. What is that landscape and the fact checking of that? Because I do think we should be held to account for what did we say we were going to do? How are we doing it? What happened? What are the reasons? What are the opportunities? And that's a healthy civic conversation to have. So I just underline that too, Brian. I think that's just a general issue that we should care about regardless of what's on the ballot. So.
Brian and Heather, and for the good of everybody else, the steering has hired, right, Pyramid Communications. And to Brian's point, we realize that a lot of good work gets done and very little gets spread or told to people in ways that they can hear it, or information sources where they go. So just really, yes, took that on the chest, not doing great at this, really trying to do better in 2023. And as a coach, I'd like to just bring an update from steering on the most recent activities. To Brian's point, it's not the whole jail tax, but it is at least a little bit about how do we promote and how do we share information from the task force. And my apologies, folks, we are a little bit over time. Jill, I'm going to have to wrap us up, and I want to find out, do we have anybody that's present that might wish to speak for public comment?
We do have 2 attendees today. If either of you would like to speak to the committee, please virtually raise your hand now. And no hands are raised.
Thank you all for such a robust and great discussion with our Lummi neighbors. I think there's a lot of food for thought. Future items, I think, that it came to the top is data. We'll get an update from steering on our communication, and maybe we might want to debrief a little bit, because it is something in motion very fast for this committee to see, because I don't think y'all are there as part of the stakeholder advisory. It'd be good to get an update on that, and then we will continue to hone our 2023 priorities. Thank you all for your attendance and for your caring, and our meeting today is adjourned.